the fluid balance and resuscitation. The perioperative factors that affect patient fluid requirement. How do we estimate maintenance fluid requirement? What are some common conditions associated with preoperative fluid deficit? List potential physical laboratory finding in patients with a volumic deficit. How do we calculate patient preoperative fluid deficit? And discuss potential mechanisms that account for preoperative fluid losses. Okay, the fundamental goal is to deliver adequate oxygen to the tissue. The extreme of fluid management have negative outcome or detrimental outcome. In either way, if we overload the patient or if we unload the patient, in both conditions, the oxygen will not reach the cell in an optimized way. We calculate preoperative fluid loss as the amount of time the patient took the PO intake. Estimated maintenance, we follow the 4-to-1 rule. 4 ml first 10 kg, 2 ml per kg for the second 10 kg, and every 1 kg afterwards, 1 ml per kg. For example, if the patient is 10 kg, weight is 10 kilos, he will need 40 ml per kg. If he is 20 kilos weight, he needs 60. And if he is 21, 22, 23, we'll give him 61, 62, 63 ml per kg respectively. هذا empirical treatment for if the patient is not taking MPO. We calculate the anticipated surgical fluid losses intraoperatively if minimal, moderate, or severe trauma. If it was minimal, 2 ml per kg per hour. If it was moderate tissue trauma like cholecystectomy, 4 to 6 ml per kg per hour. If it was severe tissue trauma like bowel resection, 6 to 8 ml per kg per hour. We adjust unanticipated fluid losses. The common recommendation, if there are bleeding, we give 3 ml of crystalloid for every 1 ml blood loss. Okay, this is distribution of body water, commonly administered in 70 kg men. 70% of the weight is water with the cations sodium 140, but potassium 4, and magnesium 1.5, and calcium 2.5 millimole per liter. The capillary basement membrane, permeable to ions, impermeable to protein. The cell wall is permeable to water, impermeable to most ion. Intracellularly, the sodium is very low, 10 ml per liter, and the calcium is 0. Potassium is very high, excess sodium, 150. The anions, protein phosphate low in chloride and bicarb. The amount of intravascular fluid about 3.5 liters, interstitial fluid about 10.5 liters, or both of them are called extracellular, 20% of total body weight, 14 liters. The intracellular fluid is about 40% of total body weight, which is 28%. So how do we assess fluid status? ما عندنا indicator واحدة. We have many indicators that can assess this process. The fluid balance chart, in the anesthesia sheet, we mention every 15 minutes the input, the output chart should be useful, but in practice maybe inaccurate. ممكن أخذ بريك رجعت ما كتبت اللي أعطيته. That's all. The normal central venous pressure, which is a catheter. We inject it directly in the internal jugular vein, and we advance the catheter up to the superior vena cava. We measure by direct manometry, usually the reading from 4 to 8 millimeter mercury, and gives an indicator of the right ventricular diastolic pressure. Not a direct measurement of hydration status, but very good at telling us if there is a change of volume. يعني the patient sudden decrease in body fluids while the patient is the same position وما حد لعب في النك. يعني ما انضغط شيء ولا حاجة ولا حطوا ايتم بالغلط فوق رقبته، ما حيعطينا اي ريدنج خطأ. هيبقى حيعطينا decrease or increase accordingly. Of course, we can insert a esophageal Doppler, which is an ultrasound probe. We pass it down the patient's esophagus, and we can visualize the left ventricle filling rate, and if there are changes during systole and diastole. And we can measure every cardiac parameter, for example, cardiac output, the anyway, the filling rate and so on. We can measure by arterial or blood sampling. We can measure the lactate level and pH, and we measure the urine output intraoperatively, which is not reliable because of surgery causes a stress response and reduce the urine output. And we can examine the capillary refill and weight of the patient. This is the Starling curve I mentioned just before. The y-axis shows us the stroke volume, and the x-axis shows us the left ventricular and diastolic volume, which is the preload of the patient. We'll have a linear increase of stroke volume the more we preload the patient until we reach in this area the patient is underfilled. The more we give them the fluid, the less stroke volume, until the point of maximum stroke volume is achieved, which is the patient ideal zone. We want patient to be in this position. And afterwards, if we overload the patient, the stroke volume will drop, which is called the Starling curve. This is the esophageal Doppler ultrasound I mentioned before. We can, it's a usable tool. We can measure hydration status of patients, not routinely used. So what are the IV fluids used? Crystalloid, those are contained sodium in similar concentration plasma are rapidly distributed throughout the extracellular space. About 30% of this fluid remain intravascular. If it contains less concentration of sodium in the plasma, for example, D4 0.15% saline, 18% saline, once the glucose metabolized, the remaining fluid is distributed through the entire body weight, and roughly 10% will remain intravascular. Means it is poorly, not ideally to be used to replace intravascular volume. So the colloids, the other part, those are suspensions of high molecular weight particle, mostly common used, are made from gelatin, protein, starch, and so on. The colloid primarily respond to intravascular volume and can initially be given in a volume similar to the deficit, meaning if the patient lost 100 ml of blood to reach the same, to replace the same fluid in the intravascular space, I have to give 100 ml colloid in response to 100 ml blood loss. However, they have a finite lifespan in the plasma and will eventually will either be metabolized or excreted. Thus, it's not an ideal use if patient in prolonged setting, like patient in the ICU and has volume deficit in the long term. So blood and blood products. The minimum acceptable hemoglobin factor affecting in the use of blood products calculated هذه المواضيع راح نتطرق لها. Calculate acceptable blood loss, the routine screening test of banked blood, side effect can occur with the transfusion, indication for transfusion of fish rolled plasma, cryoprecipitate, and platelets. Okay, blood and blood components. Whole blood, ناخذ blood زي ما هو ونعتزل ما هو. It contains red cells, plasma protein, clotting factors. There are no platelets, however. Not widely used until the unit, not widely used. Each unit is about half liter with hematocrit similar to the normal value. Meanwhile, the packed RBC, PRBC, each unit contain about 300 ml with concentrated hematocrit, about almost double concentration of RBC than whole blood. with optional additives, saline, adenine, glucose, mannitol. Usually are not recommended to be given unless if hemoglobin less than 70. It's likely to be appropriate. If it was less than 60 gram per liter, transfusion is recommended as there is a risk for ischemic cardiovascular disease. Patient with chronic iron deficiency will need higher hemoglobin level. As if the hemoglobin level above 9.0 or 90 gram per liter, it's inappropriate and will put the patient in complete risk with no benefits, except in certain conditions. Below 90 and above 70, it's likely to be appropriate if there are signs and symptoms of impaired oxygen delivery, like tachycardia, hypotension, cardiac ischemia, syncope, and presyncope. Okay, other indications of RBC: acute blood loss to maintain hemoglobin above than 7 during active bleeding. Consider for higher hemoglobin level target in patients with unstable or acute coronary syndrome, coronary artery disease, uncontrolled and predictable bleeding. And patient in critical and coronary care, we consider transfusion when hemoglobin is less than 7. And patient with post-cardiac surgery, we should maintain hemoglobin above 9 milligram per deciliter at all time, or 90 gram per liter. Okay. For patients with chronic anemia, we transfuse only when there is alternative do not exist or have failed. We administered RBC at interval to maintain the hemoglobin level just above or lower concentration that is not associated with the symptom of anemia. So we assist those patients are expected to have long-term transfusion-dependent survival for iron overload, since the iron content is more than the patient needs. It's typically iron overload is present after 20 units of RBC. Patient with significant component of ineffective erythropoiesis and unregulation of iron absorption may become iron overload much more quickly than normal patient. We should monitor serum ferritin, transferrin saturation. Tissue iron overload is likely if ferritin more than 1,000 mics per liter and transferrin saturation more than 70%. Deferoxamine, deferoxycyrox and deferriprone are available agents on iron chelation with target ferritin between 500 to 1,000 mics per liter. And appropriate monitoring for drug toxicity referred to package insert. The platelets. We do not transfer platelets if the platelet is more than 100 or 10 times 10 powered by 9. بس احنا بنختصرها دائما 100 with no bleeding or anticipation of drop less than 100. For patient with diabetic thrombocytopenic purpura without major hemorrhage, even when platelet count less than 100, we should not give them platelets. For patient undergoing procedure more than 6 hours later, give as close to procedure as possible. For minor procedure with platelet count more than 200 percentage or percentage. If it was less than 100 pre-surgery or head trauma, we transfuse one pool of platelet. If it was less than 50, usually we give the platelets for epidural anesthesia, lumbar procedure with blood loss or major surgery more than half liter, or patient with immune thrombocytopenia. And below that, it is usually indicated below 20. If the patient has a history of platelet dysfunction, marked bleeding, post-cardiopulmonary, for example, post-cardiac bypass surgery, we usually transfuse one pool of platelet alongside with RBC. Exception, transfuse platelet for intracranial hemorrhage, not requiring surgical management in patients antiplatelet agents. lead to increased morbidity mortality. Okay, fresh frozen plasma is frozen within 24 hours of collection, and apheresis fresh frozen plasma is frozen within 8 hours. FFP and FFPA contain about 400 to 900 milligram of fibrinogen and per 250 around equivalent, or about 4 units of FFP contain about 2.5 grams of fibrinogen. The biological half-life of plasma coagulation protein is different for each protein. Factor 7 is the shortest one, about 3 to 6 hours. Factor 8, factor 8, 8 to 12, and 2 to 3 days for factor 2 and factor 9. To determine if FP frozen plasma is indicated for abnormal coagulation, test results. The cause of the evaluation must be determined. Liver disease versus warfarin effect versus singular effect deficiency. It's indicated in bleeding prior to significant operative procedure. Patient with INRPT, PTT 1.8 times normal or greater due to multiple factor deficiency with no coagulation factor concentrate or other alternative therapy. Microvascular bleeding or massive transfusion, and patient clinical status precludes waiting 30 to 45 minutes. For INR, PT, PTT results. Thrombotic thrombocytopenic patients. We don't transfuse plasma in the following situation: bleeding INR with INR less than 1.8. Even if it was intraoperative. INR elevated, but patient is not actively bleeding. We usually give warfarin reversal with heparin low molecular weight reversal. Factor 10A is factor 2A inhibitor anticoagulant reversal, and high level of APTT with normal INR. Cryoprecipitate, it contains factor 8 and factor 9 fibrinogen von Willebrand factor. Each unit of cryoprecipitate contain minimum about 150 of fibrinogen. It's indicated in bleeding with fibrinogen less than 1 gram per liter, and massive hemorrhage with fibrinogen critically low level, less than 2. For acute phase of acute myelocytic anemia, with fibrinogen less than 1.5, intracranial hemorrhage with fibrinogen less than 2. Treatment of bleeding patient with von Willebrand factor hemophilia only when patient concentrate are available, and if desmopressin or DDAVP is not available or ineffective. Okay, storage concentration, condition, and volumes. Most of them are stored in the fridge, except for platelets, stored in room temperature. For the red blood cells, stored for 42 days at temperature 1226. Platelets stored for about 5 days in regular temperature, 20 to 24. Even apheresis platelets, 20 to 24. Platelets tend to deactivate when frozen. That's why platelets have higher risk of contamination, of bacterial contamination. Frozen plasma, it's minus 18 deep cold. Also apheresis plasma cryoprecipitate. And for to thaw the ice, should be waited for about 30 minutes. Meanwhile, since platelets is readily available, should be given within no time. Okay. All transfusion reactions are mild to life-threatening, and transfusion error must be reported to the hospital transfusion service, the blood bank. Those reactions include fever, dyspnea, urticaria, other allergic reaction, anaphylaxis, hypertension, hemolysis after transfusion, cytopenia after transfusion, and infection. So fever and shaking, if there is more than 1 Celsius increase in temperature, and temperature more than 38 Celsius during or up to 4 hours post infusion. Immediate management should stop infusion and maintain IV access we take patient vital signs, recheck identification, patient blood product أبدا ما نرمي الكيس. Physician assessment of course it's required, notify hospital transfusion service and the blood bank even if transfusion related or completed. Okay, clinical or serious symptoms, temperature is more than 39, and hypertension, shock, tachycardia, shocking, chills, rigors, anxiety, dizziness, and so on. If it's not available, we administer paracetamol. We continue infusions cautiously under observation, likely febrile, non-hemolytic transfusion reaction. We stop if the patient develops one of the above symptoms. If there is, we do not restart infusion. We suspect hemolytic transfusion reaction or bacterial contamination. Then we collect blood bank specimen to recheck the ABO group, clamp tubing, send unit to blood bank along with attached IV solution for bacteria culture and stain grams, and send first post-transfusion urine of the patient, check for myoglobin, and send blood culture on patient taken from the different IV sites. Okay, bacterial sepsis or contamination. It's usually serious, carries serious morbidity mortality, and most frequently with gram-negative bacteria, but are also reported with gram-positive bacteria. A number of bacteria have been implicated, like E. coli, Serratia, Mersinus, and Staphylococcus aureus, and so on. For the risk of bacterial contamination, in the packed RBC is 1 in 50,000. If it was fatal, 1 in 500,000, or only symptomatic septic reaction, 1 in 250. For the platelet pool or apheresis platelet, the risk is almost 10 times more than RBCs. More than 10 times actually. 20 times more. Up to 50%, not 500 times. Bacterial sepsis account for at least 10% of transfusion fatalities and occurs more frequently due to their storage temperature, and about 2/3 of gram positive and 1/3 gram negative, which carries the most serious condition. Okay. Acute hemolytic transfusion, it usually happens if there are errors or ABO compatibility or other groups incompatibility. It happens about 1 in 38,000 RBC transfusion due to transfusing the wrong blood to the patient. Less than 10% of ABO compatible transfusion result in fatal outcome. Over 50% have no morbidity from ABO compatible transfusion. Risk of death correlate with the amount of incompatible transfusion. The more than we give, the higher the risk. The most common presentation is fever, chills, hemoglobinuria. Management, we stop transfusion. We check for error, notify blood bank, and return residual blood product, and send first post-transfusion urine specimen, and we provide supportive care. Febrile non-hemolytic transfusion reaction, it's usually mild, soluble factor like cytokines in the plasma and component transfused. Recipient antibody react to antigens expressed in the cell, component usually in white blood cells. Management, we give acetaminophen, meperidine. Anyway, most of the blood product that we have been cell and washed and decreased leukocyte reduction. Which carries the risk about 300 in the RBC and the platelet 1 in 20. Transfusion reaction, dyspnea. Management, we stop transfusion, maintain IC, take patient vitals, recheck identification, physician assessment, notify patient hospital transfusion service, return clamp blood unit with tubing action, attach. We consider transfusion-related acute lung injury. We rule out transfusion-associated circulatory overload or TACO. We rule out anaphylaxis. If TRALI or transfusion-related acute lung injury is suspected, we notify hospitals, transfusion service, so the special donor and recipient testing can be performed. We ordered stat chest X-ray. Rule out ARDS and oxygen diuretics and supportive care as required depending on the type of reaction. So, TRALI, its definition, it's acute lung reaction, injury. It's acute and onset hypoxemia, defined by hypoxemia. FiO2, PaO2 over FiO2 means alveolar على الارتيريال O2. في عندنا فارق قل من 300 millimeter mercury or oxygen saturation less than 90 in room air. Bilateral lung infiltration on chest X-ray and no evidence of circulatory overload, meaning patient is not volume overloaded. Definition of TRALI, patient with no evidence of acute lung injury prior to transfusion. It's diagnosed with a new acute lung injury within 6 hours of completion of transfusion. There are no risk factor, other risk factor for TRALI. Incidence about 1 in 1200 to 1,500 or 5,000. Chest X-ray of patient before during episode of transfusion acute lung injury. After about 1 day, as bilateral chest X-ray, infiltration chest X-ray. Okay. TACU, or transfusion associated circulatory overload, result from has much similar condition, clinical feature like a TRALI. It results from impaired cardiac function or excessive rapid rate of transfusion. Happens 700 up to 8%. Patient over 70 years of age. Risk factor includes the patient over age of 70, infants, patient with severe volemic anemia with hemoglobin less than 50, renal impairment, fluid overload, and cardiac dysfunction are particularly susceptible. Okay, massive transfusion. I mentioned before. What is massive transfusion? It's more than administration of more than 10 units of PRBC transfusion, more than 1 unit volume, 1 blood volume in 24-hour period. Complications depend on number of unit transfusions, rate of transfusion, and patient factor. The faster the rate, with the higher morbidity from the patient, the higher the complication. Usually what happens is dilutional coagulopathy, hypothermia, hypocalcemia, metabolic acidosis, and hyperkalemia. طبعا عندنا يعني for in those patient which we prescribe this massive transfusion, it has to be followed the massive transfusion protocol or massive hemorrhage protocol. Every hospital must have massive hemorrhage protocol to ensure standardized care delivered. We should promptly use measures to prevent hypothermia, include use of blood warmer, monitor core temperature, watch for dilution coagulopathy every 1 hour, and watch for hypocalcemia, acidosis, hyperkalemia. Blood tubing must be changed every 2 to 4 units to reduce the chance of sepsis and contamination.